Good morning everyone and welcome to the B&B Dental channel. This is Dr Banzi Angelo. Today speaking about a review of the literature about the guided surgery technique, the accuracy of the surgery technique. Let's start. History of medicine has always been made by research, challenge and pledge. Medicine is part of a revolution that has changed our life. Today what we are living is a real digital dental revolution. In fact, working with files, we will be able to have the virtual imaging of the bone of the patient. We can design a smile, a prosthetic smile using a software, or taking a virtual impression by using an intraoral scanner. With surgical software, we will be able to planning the position of the implant, and with extraoral scanner to get the impression of a plaster model. CAD/CAM system to design the virtual imaging of a radiological template or a prosthesis, and using milling machine, laser sintering machine or 3D printer, we will get the final prosthetic rehabilitation. This is what it is living and working with the digital revolution. And but what does it mean, digital dental revolution? It means, as I told you before, that today we don't need any other material than file to get an entire prosthetic rehabilitation. Now, the question is, what it is a file? A file, it's a numeric data, it's untouchable, it flies in the air, and you can collect it in a library, virtual library that we better know as cloud. And how can we work with this untouchable number? Just follow 3 operative steps: acquisition, elaboration and production. The acquisition comes from scanners. The most famous scanners in the world is the CT Conbin. The CT Conbin allowed us to get the virtual imaging of the bone of the patient and creating DICOM files. Then we have other scanners like intraoral scanners and extraoral scanners. Intraoral scanner and extraoral scanners allowed us to have the virtual imaging of soft tissues and teeth, creating STL file. Finally, the reflex. With the reflex, I'm going to get the virtual imaging of the smile of the patient at the beginning, during and post-surgery and prosthetic rehabilitation, creating JPEG or RAW file. It's up to you which one you want to use. After the acquisition, it comes the elaboration. The elaboration, it's made thanks softwares. We can work with smile design softwares that allowed us to have a sort of virtual workshop. That it's very important for the patient because it's is going to understand the final aesthetic rehabilitation of the case, and for us to know the space required from the prosthetic rehabilitation. Then we have the surgical software. The surgical software allowed us to perform a virtual surgery. With the surgical software, guided by a radiological template, I'm going to decide the implant position, and also I can choose the type of abutment I want to work with. For example, the angulation, the parallelism of the abutment. It's not only placing virtually an implant, but it's the entire system that I'm allowed to work with this software. CAD-CAM system. The CAD-CAM system, it's actually the technician that work with this software, and with the CAD he is able to design the virtual image of the surgical template, but he will be also capable to virtually design the prosthetic rehabilitation. After the elaboration, it comes the production. The production, it's made thanks machineries, and working with different type of machineries, I will be able to have the surgical template and the stereolithographic model, for example, of a maxilla, just using a 3D printer. And with milling machine or laser sintering machine, I'm going to have the metal part. I'm going to create, the technician is going to create the metal part of a removable prosthesis, or a single crown working on different materials, or a bridge, or a circulary. Temporary, definitive prosthesis, we can get all the system. The radiological template, and with the extraoral scanner, or also the intraoral scanner, I can get the virtual imaging of the soft tissues, teeth, and radiological templates. Once that I've got these two files, the one of the bone of the patient wearing the radiological template and the one of the radiological template, I can match these two files together. Once that the match has been done by the technician, it can be elaborated by a software, the surgical software. With the surgical software, the doctor is going to decide the precise implant position guided by the radiological template that is a copy, normally it's a copy of the final prosthesis. Then when I decide the position of the implant, the technician can, with the CAD-CAM system, with the CAD in this case, design the radiological template and the prosthesis. After the elaboration, it comes the production. 3D printer is going to print the surgical template and the plastic model, the copy of the maxillary of the patient. And with a milling machine, the technician is going to create the prosthesis, temporary or final prosthesis. We can get both of them. A bit of history, because guided technique has got a father, and it's almost 18 years old. The father of this technique is Daniel Vanstenberg, that in 2002, working with a very famous company on his idea, he published a clinical report case where he was able to fix in 6 patients over 8 implants a definitive prosthesis. Yes, I'm not joking, it's a definitive prosthesis. And what is said about this technique is that this procedure permitted that the placement of a definitive fixed prosthesis with limited freedom of space between the abutment and the metal cylinders incorporated into the prosthesis. This affirmation sounded like a bomb for the surgical world, because think about the fact that in just one section you are able to place, to perform the surgery and fix the definitive fixed prosthesis. All the work is done in just one day. But if we read better the affirmation, we know also that we need a limited freedom of space between the abutment and the cylinders that are incorporated into the prosthesis. This limited freedom of space, what is it? Well, actually, we can call it as tolerance. A tolerance between the abutment and the metal cylinders into the prosthesis. But the tolerance, what is it? The tolerance is actually it's an inaccuracy. We can call it inaccuracy. Yes, because in guided technique, this word it's really important. What do I mean when I say accuracy? Accuracy is actually the maximum deviation between the virtual imaging of the implant when it's compared with the real position of the implant. And as you can see from this imaging, this is actually one of my first case that I have done with the guided technique, and is actually fixed over teeth, so it's a teeth supported guide template. Well, actually, as you can see from this imagine, the last picture is the comparison between the virtual imaging and the real imaging. And as you can see from each implant, this matching fit perfectly. I mean, what is the position in the virtual world, it's the same in the real world. So we can say that in this case I reached a very high accuracy. Okay. But why do we have this freedom space, this tolerance, this inaccuracy? Because if I have to be honest with you, no, it doesn't exist the precision or the 100% perfection in this system. We can reach, we can work close to this percentual, we can say, but it's never 100%. Why? Because the guided surgery technique require a workflow. And this workflow it's made of 9 operative steps, and in these 9 operative steps we can bring inside the system errors, and error in guided surgery technique are cumulative. What does it mean? It means that error over error, we are going to get a big final error that can fail our technique, our rehabilitation. I mean, and it's really important to talk about all the possibility to enter in this system, this error, to avoid them. Yes, because error can be entered during the data capturing, error can be entered during the implant planning, error can be entered during the guide manufacturing, and error can be entered also during the surgery. Okay, just to refresh, to have an idea of what we are talking about this system. The guide surgery technique has got a workflow, and the first workflow was made by Daniel Banzenberg, starting by using 2 files coming from a double CT scannerization. The first file, it's the patient wearing the radiological template. It's a DICOM file. The second file, it's the DICOM file of the radiological radiopack template. And these 2 files that I have to be matched together. Once that the matching is done, a software can be read this matching, and working on this software, the doctor is going to be able to decide the position of the implant, guided by the information that it gets from the radiological template. Once that the implant positioning have been done, we can send the information to our technician, and our technician is going to design virtually with the CAD the virtual imaging of the surgical template. Finally, with a 3D printer, is going to print the real surgical template and the prosthesis. Does this workflow works? Yes, it works for every case, but the problem is the fact that the double CT combine scan technique, the one that it's the original one, it doesn't really work in a good way or with an high accuracy in case of the presence of metal in the mouth of the patient. Yes, because metal that we can find in prosthetic part or in the removable or the metal part of a removable prosthesis. Also the removable the resin that we use to rebase the removable prosthesis can contain in the liquid part metal. Well, actually all this metal in the mouth of the patient can create a deformation during the CT combine exam, and a deformation can create a problem of precision. It brings a problem of precision. So during this year it has been presented an alternative workflow. This alternative workflow do not require a double CT combine, but it requires just one CT combine of the patient wearing the radiological template and the plaster model. With the plaster model, and the plaster model is going to be scannerized by an extraoral scanner. With the extraoral scanner, I'm going to get an STL file that you can see from the image. This scannerization, extraoral scannerization, allowed me to have the information about soft tissues, surgical radiological template and teeth. Once that I've got all this information, I can match the STL file with the DICOM file coming from the CT combine. And this is the final imaging, the bone coming from the CT combine and the soft tissue teeth, while the soft tissues, teeth and radiological template comes from the scannerization with the extraoral scanner. This is really important because it's the only difference between the two workflow. The beginning, because then it's always the same. With a surgical software, I'm going to planning virtually the implant insertion. With a modeling software, I'm going to the technician is going to design the virtual design of the surgical template, and with a 3D printer, the technician is going to print the real surgical template, and with a milling machine, the prosthetic rehabilitation. Actually, this alternative workflow that use the extraoral scanner, it has been studied by Mario Beretta, and Mario Beretta has checked the accuracy of the double CT combine exam, the original, we can say, the traditional technique, with this new method, alternative method that use the extraoral scanner. And the results are really interesting because in angular deviation and global deviation we notice better accuracy and high accuracy. And as you can see from this imagine, the double CT combine has got a coronal deviation and apical deviation higher than the alternative method, and the angular deviation as well. So it seems that the alternative method works better than the original one. Do we have another method? Yes, we actually have a third workflow, a third alternative workflow. And this is this workflow do not use the extraoral scanner, but it uses the intraoral scanner. And this is better because with the intraoral scanner I don't need to use any radiological template. This is really important. With this workflow I am not using any radiological template. Yes, because I just have to take the virtual impression by using the intraoral scanner. This virtual imaging is going to be matched with the DICOM file coming from the scannerization made with the extraoral scanner. This is the imaging that we are going to have, final imaging, and the rest is always the same. I mean, surgical software to place the implant position, modeling software to design the virtual surgery software, surgery template, the 3D printer to print the surgical template, and finally the milling machine to get the prosthesis. And as you can see from this imagine, this technique is allowed, but just in case of short dental prosthetic rehabilitation like two teeth or single tooth rehabilitation. And I'm going to show you later why. So remember these important things. You can work with the intraoral scanner, but just for single tooth rehabilitation and short dental rehabilitation. So let's move on. Which case can I handle with this technique? Well, actually, I can handle every case. I mean, I can work with full arch rehabilitation, partial arch rehabilitation, single tooth rehabilitation. And the workflow, the operative workflow is always the same. This is the only thing that change. I need one file coming from the CT Combine and giving me the idea, the virtual idea of the bone of the patient. The second file, it comes from the CT Combine, an extraoral scanner or an intraoral scanner. Once that I've got these two files, I can match them together, and with a software I'm going to read, I'm going to decide the position of the implants, and with the CAD system the technician is going to design virtually the surgical template, and with a 3D printer is going to create the real template that I'm going to use for the surgery, as you can see from this imagine. And this is the final results. Checking with the CT Combine, you can see that the implant are placed bone level. These are the first case that I have made with this technique. They are all bone level, perfectly centrated into the bone. So, which case can I handle with the original technique? Every case. I mean, I can work with the full arch rehabilitation. I can handle partial arch rehabilitation or single tooth rehabilitation. But remember, this is really important. If you have metal in the mouth of the patient, and remember that the metal can be also in the resin that you use to rebase the removable prosthesis. So be very careful, check the liquid part especially can have metal. Yes, because metal, as I told you before, can create a deformation. So the original method, the double CT Combine, allowed me to handle every situation, but when in the mouth of the patient there is no metal. In case of metal, I recommended you to use the second method, the second workflow. The second workflow require a CT combine imaging of the patient wearing the radiological template and the STL file of the plaster model and the radiological template. Finally, the intraoral scanner, intraoral scanner allowed me to handle only the single tooth rehabilitation or short dental rehabilitation. Let's move on. And let's start talking about the errors that can be entered into the workflow, into the system during the data capturing. The data, as you can see from this imagine, the capturing of the file comes from again the CT combine or the extraoral scanner or the intraoral scanner, and these are the imagine that we will get. We are going to get the soft tissues, the bone, and radiological templates, teeth. But what about the error? The errors. The first errors comes with the CT combine. It's the movement of the patient. Yes, because during the exam, if the patient move his mouth, we can have a problem of the final imaging of these exams, and it's going to be to fail. And if the final imaging is not clear, we cannot, the technician cannot work on file that it's corrupted. Metal artifact. Metal, as I told you before, the presence of metal in the mouth of the patients can create a deformation of the imaging. And this deformation is better known as scattering effect. And again, remember that the metal is not only the single crown, the metal part of the single crown or a bridge. The metal is also in the liquid of the resin that you use to rebase the removable prosthesis of the patient. So full arch rehabilitation doesn't mean that does not have any metal. And the deformation, it's quite big. It's a big part of error that it's a big part that brings into the system a very important error. CT parameters. Remember that the CT combine it's machineries. So every year, once a year at least, it has to be set by a technician, a professional person that is going to check the parameters. Yes, because in literature are reported cases where the range of error for the CT combine goes from 0 to 0.4 millimeter. You can understand that 0.4 millimeter it's a very big error to enter into the system. What about the extraoral and intraoral scanner? Well, checking the literature, Sason made a comparative study between the intraoral and the extraoral scanners. And what we know about these studies is that the intraoral scanner seems to be more precise and trueness compared to the extraoral scanner, especially the range of precision. But this range is not so different, as you can see from this affirmation. But what we can find out from the literature is the fact that yes, the digital intraoral impression works in this range of precision in case of single crown or short fixed dental prosthesis. In case of full arch impression or long fixed dental prosthesis, all the author agree to the fact that it's better to use the conventional impression technique. And really interesting is this article, this lecture of Ender, where he tested the two type of impression, the virtual impression with the analogic, we can say. Well, it's not analogic, I mean using material like elastomeric material or hydrocolloid material. And what it comes out from this lecture, this article, it comes out that the most precise technique is using the double impression with elastomeric material. Yes, the double impression, you heard really well, the double impression, it's more precise. It's more precise compared to the intraoral scanner. The worst material that you can work with, it's actually the alginate. So the traditional technique, it seems to be more precise than the virtual technique. Implant planning. During the implant planning, I can enter error, and let's see this error. Yes, error of valuation. Yes, because not all the patient can be treated with this technique. I mean, for example, patient with temporomandibular joint disorder, obviously they cannot work with this technique because the patient have to keep his mouth open for a long time, and you have to work with a surgical template with a very long drill with the one piece in the mouth of the patient. So at least remember, it's require minimum open a minimum opening mouth of 3 centimeters. And then remember that not all the case can be treated with this technique, especially when a patient come to my clinic with a removable prosthesis. We think that I rather work always with this technique, but not always I can, especially in this case, in that case where the removable prosthesis of the patient slide laterally because of the fact that there is just basal bone and not alveolar bone. Well, in that case, I already know in advance that I'm not going to be able to find a good position for the radiological template, and remember that the same position is required for the surgical template. So if I cannot have or find a good position of the radiological template, how can be possible to find the same position for the radiological template? This is really, really important. And the problem is not only when I have a big resorption of the alveolar bone, but is also when I've got too much soft tissues. Yes, because when I've got hyperplasia, or when I've got that floating crest that you touch and you can move back up and down, well, actually in that case the ductility of the tissues is too high, and this is going to be a problem because I cannot find the right position of the radiological template and surgical template. So in case of a very thick mucus, remember, try to cut, to eliminate this thickness, and then you can work with reduce this thickness, and then you can work with this technique, the guided technique. Let's go with the planning time, the implant planning. Remember that a minimum space of 6 millimeter is required for the sleeves. So if you don't have 6 millimeter between two teeth, it's impossible to work with the guided technique. Also, if when you planned, but we are very lucky because the technician, if he's a good technician, he can adjust this problem. When I'm planning, sometimes I forget to check for the sleeves, and the sleeves has a distance from the head of the implant of 4 millimeter. Okay, it's this 4 millimeter doesn't change. Okay, are always the same. This made the guide technique predictable. Well, when I work, maybe sometimes I want to place the implant 1 or 2 millimeter under the level of the bone because I prefer to use shorter implant, but always 1 or 2 millimeter under the level of the bone. And sometimes the sleeves, as you can see from this image, can enter into the soft tissues, or maybe I choose an inclination of the implant that brings the sleeves into the soft tissues, or close to one teeth, or close to a papilla. What does it mean? It means that in that case, most of the time I'm supposed to open a flap, even if I want to work flapless. Well, actually, we from B&B Dental have developed this trick that you can play to avoid to open any flap and work flapless, just moving up the sleeves of 2 or 4 millimeters, and the kit has got all the tools to allow me to place the implant in the right position, even if the sleeves has been moved of 2 or 3 or 4 millimeter. But I'm going to explain you better. It's just a trick to avoid the fact that the sleeves is into the soft tissues. Other problem is when I don't check the right position of the radiological template. I mean, like you can see from the first image, it's a maxilla, and the radiological template detached from the soft tissues. Yes, because you can see that there is a black spot. This black spot, it's because there is air. The radiological template detach from the soft tissues, and this is a problem because it's not in the right position. As is not in the right position, the second image where you can see the soft tissue, the prosthesis, the radiological template that slide behind the position, and this happen frequently, especially when there is no alveolar bone and just basal bone, and there is no bone to search for a good fitting of the radiological template over the mandible. This is an item that B&B Dental has introduced to reduce this problem. And yes, because some brands use Guttaperk as a radiopack marker. Some other use some sort of Lego toy fix over an arch. Well, actually, what we use are these radiopack marker, very small, little, rounded. They are very easy to be used because you have just to attack this marker over the radiological template. 5 of them, and it's done. The work is done. Another item different from the other brands is the fact that we support the fact to use the pick sleeves. Yes, because we started working with the metal sleeves, but metal sleeves can affect the optimal implant position. I mean, when a metal, the drill, rotate inside these sleeves, it can be possible to create an effect that is better known as friction effect, and this friction effect create a problem of working of the drill, rotation of the drill inside these metal sleeves. So to avoid this problem, we decided to work with the pick sleeves. Pick sleeves are amazing. It's an amazing material, and they don't have a big, so high friction working with the drill inside the pick sleeves, and this allowed me to have a final sleeves smaller and so much more precise than the metal sleeves. Yes, because the metal sleeves have to be kept bigger to avoid the problem of the friction. Also, this material, it's an amazing material because it has less overheat, and it doesn't burn the soft tissues that touch the sleeves. Let's move on with the guide manufacturing errors. And if we check from the literature, we will we can find out that some author has studied, like Sommakal did, has studied the 3D printer machineries. Yes, because we can have different type of 3D printer machinery. This is really important. Yes, because if we want to have a precise surgical template, remember that the 3D printer, it's really important. I mean, it has been shown that 3D printer that create a layers lower than 20 micron are able to create a much more precise surgical template than 3D printer machine that create surgical template with layers of 50 micron. So remember, thinner is thinner is the layer that the 3D printer is going to create, and higher will be the accuracy of the precision of the surgical template. Richard, other author, has studied the sleeves and the error that comes from the sleeves, and in his article what we can find out that the deviation increase in case of long implant length and large drill K diameter. This is this is true. Longer is the implant, and higher is the possibility to have a deviation of the final position, and larger is the drill, so more operative steps, more drill I'm going to use, and higher will be the possibility to change the position of the implant. And this is also related to the fact that shorter sleeves or drill K heights can conditionate this situation. This is really important. never change the sleeves. Sleeves have been studied to have a dimension, an height, a width that can guide properly the drill and the implant positioning. Shen, it's the author that has studied the sterilization. Does the sterilization can create a deformation of the the surgical template? Yes, it does, especially the heat sterilization. If you want to sterilize your surgical template, it's important that you use or the plasma gas sterilization or alcohol, at least 70%. Finally, we got another technique. I reported another technique to make the surgical template, and this technique I can call the analogic technique. It uses a milling machine to transform what the radiological radiopack template in a surgical radiopack template. The same template that I use for the radiological exam, I am going to use for the surgery. And it's a milling machine that drill the hole with the right inclination, but the system brings too much error into the system. So it's more if I have to be honest, it's more accurate working with the digital technique than the analogic technique. Let's see the last part of the error that we can bring into this system, and they come during the surgery. I made a research in the literature, and you can find more than 300 articles from in these 13 years. And what I was looking for was an article with a similar operative procedure, in vivo studies, teeth and mucus supported guide, and all the studies that bring information about the angular deviation and the global deviation. And at least what I can find out is what I could find out is the fact that all the authors agree with the fact that with the idea that the tooth supported guide has a smaller deviation compared with the mucosa supported guide and bone supported guide. As you can see from the table, the score of the table, the angular deviation of the tooth supported guide is lower compared to the angular deviation of the mucosa supported guide. Why? Because of the teeth. Teeth are the best pillar, the best fixation system that you can work with this system. Let's see other items finding out with from the literature. Bone density, type of bone, mucosal thickness, surgical experience, smoking habits, implants length, and fixation screw. Let's start with the bone density. What about the bone density? Oki, in his article, he noticed that higher is the density of the bone, and more difficult is to reach the right position of the implant. Yes, because in his opinion, when the bone has a very high density, it's very difficult to reach the position bone level. The implant stayed over the level of the bone. So in his opinion, lower is the density of the bone and higher is the accuracy. But about this item, there is a little bit of confusion in the literature. Yes, because if you check for the type of bone, we can see that Ozan said that a better accuracy comes in the mandible. This is totally the opposite what the author before said. Yes, because for Othan, the great accuracy is undemandable because of the high density of the bone. What about Patterson and Cassetta said about this the type of bone? Well, they said that a better accuracy in the maxilla because of the low density of the bone and the large area to stabilize the surgical template. You can understand that every author has an idea different from the other. What can I say to you? In my opinion, is that it's true, bone density can be a problem, but honestly, if you know your system, you can prepare the implant site in the right way to reach the level that you have already chosen during the virtual software planning. So, for example, for B&B Dental, if I work in a bone level D1 or D2, very high density, well, in that case, and I want to place a 3P or an evolution implant, I'm going to use the same drill of the same diameter of the implant, and sometimes, especially in bone D1, I'm going also to use the contour seal drill. Okay, so you have to know your system, the system you are working with, to reach the right position of the implant. What is it? What can I say to you? It's that I can agree with Patterson and Cassetta about the fact that an higher accuracy it's in the maxilla. Not because of the low density of the bone, but because of the large area that we have to stabilize the surgical template. This is really important. Also, the maxilla has got anatomical area that I can check for the stabilization of the surgical template and radiological template, like the frenulum or the tuberosity of the maxilla. These are checkpoint really important. What about the mucosal thickness? About the mucosal thickness, we know that it can affect the final implant position. Hawking and Cassetta, they notice that thicker is the mucus and higher is the global deviation, so lower is the accuracy. Why? Because of the utility. We have spoken before this problem. Yes, when when a mucus is really thick, these tissues can have an high utility. And when I work with the guided system technique, it's required to work with system that is static. I mean, the impression have to be mucostatic. The positioning of the surgical template have to be mucostatic. The positioning of the radiological template have to be mucostatic. This is really important, and you can understand that thicker is the mucus, lower will be the stability of the templates. And these authors notice also that smoker have a thicker mucus compared with a patient that do not smoke. What about the implant length? The implant length can affect the optimal positioning of the implants. And Dassen, in his article, he noticed that implants, short implant, like as you can see from this table, 8mm implant have an apical deviation lower than implant longer, like implant of 15 millimeter. This is true, and the problem is what we better know as flag effect. What is it, the flag effect? The flag effect is an effect that brings a sort of deviation of the apical part of the drill and implant. Why? Because of the fact that when I place when I prepare with the drill the bone and I place the implant, it can happen that looking for the bicorticalism, because it's very easy to work with looking for the bicorticalism working with a guided technique. The apical part can floating, the apical part of the implant can floating, as you can see from the imagine, in the trabecular bone, and hitting against the inner face of the cortical part, it can be deviate a little bit. And so remember, longer is the implant and higher will be the possibility to have a deviation of the apical part. What about the fixation screw? The fixation screw use lateral pin for most of the other brands, but for me are not enough. Yes, because lateral pin can sit in the right position, the anterior part of the surgical template, but the posterior part can be laid up. So for this reason, we introduce in our system, the B&B Dental introduce the crystal screw, and mixing the lateral pin with the crystal screw is the best way to work. And all the authors that we have seen before agree with the fact that it's important to work with the lateral pin. This is an imagine of the that show you the fact that the posterior part of the surgical template can lay down from the position, even if you use the lateral pin. And in the second on the right, you can see the fixation of the posterior area by using the crystal pin. They are very useful, and for me it's the best way to work, crystal screw and lateral pin. Okay, let's move on, and at least we got also the mounter that can work as a fixation screw. The mounter allowed me to place the implant in the right position, checking also for the right position of the hexagonal inner face of the implant. Important, really important, especially when I choose to work with angulated abutment. What about the surgical experience? About the surgical experience, we can this article, it's really interesting, because Van der Wiel made ask for two group, one of expert doctor and another one dentist without any experience in guided technique. And what we can find out that the expert group, from the table, you can see the expert group goes better than the not expert group. I mean, the implant placed by the expert group has a lower global deviation and angular deviation. But if you look at the angular deviation of not expert group, you can understand that this difference is not so high. So this is really important, 2.78 for the not expert group and 2.7 for the expert group. This is really important, because what these score, these results say to us is that this technique is predictable. Everyone can work with the guided technique, getting the same results. What about now the accuracy? If we compare the guided surgery technique with the freehand surgery technique, Well, these two articles are really interesting because they ask the same doctor to place the same implant with guided by a template and freehand. And what we find out? We find out that the guided surgery technique has an high accuracy compare to the freehand surgery. Yes, because when you place an implant freehand, the accuracy is higher than 2 millimeter. It means that the deviation between the virtual implant and the real implant is higher than 2 millimeter. Instead, with the guided surgery technique, we can work flapless, so minor bone crystal loss and less pain post-operatory. But what about the prosthetic results? The prosthetic results are the same. It works good in a good way, working with freehand surgery and guided surgery technique. My dear doctor, this is actually my presentation. I hope to show you the right way to work with this technique that I read work in every case, but again, remember, not all the case can be done. Hope these suggestion that I gave to you will help you to reach great things and great accuracy also in your daily work. So, bye.